Med breakdown. Thrive with medicine. Diabetic ketoacidosis. Introduction. State of absolute or relative insulin deficiency aggravated by ensuing hyperglycemia, dehydration, and acidosis producing derangements in metabolism. Characterized by hyperglycemia over 300 mg per deciliter. Low bicarbonate, less than 15 milliequivalent/L. Acidosis pH less than 7.30. Ketonemia and ketonuria. Pathophysiology. Insulin deficiency. Increased counterregulatory hormones, i.e., glucagon, cortisol, growth hormone, epinephrine. Enhanced hepatic gluconeogenesis, glycogenolysis, and lipolysis. Consequences of hyperglycemia. Uncontrolled hyperglycemia. Osmotic diuresis. Dehydration. Renal shutdown. Excessive lipolysis. Increased flux of FFA into the liver. Increased oxidation. Accumulation of end products. When metabolites exceed buffering capacity, then acidosis. Presentation. Signs of dehydration. Acetone odor. Signs of acidosis. Shallow rapid breathing or air hunger, Kussmaul or sighing respiration. Abdominal tenderness. Disturbance of consciousness. Signs of intercurrent illness. Diagnostic evaluation and lab studies. Urine. Highly positive for glucose and ketones by dipstick testing. Rarely, urine is negative for ketones because most of the available laboratory tests can detect only acetoacetate, while the predominant ketone in severe untreated DKA is beta-hydroxybutyrate. Blood and plasma. Glucose levels may be as low as 250 mg per deciliter. Sodium. The osmotic effect of hyperglycemia moves extravascular water to the intravascular space. For each 100 mg per deciliter of glucose over 100 mg per deciliter, the serum sodium is lowered by approximately 1.6 milliequivalent/L. Potassium. This needs to be checked frequently, as values drop very rapidly with treatment. Bicarbonate. Use in conjunction with the anion gap to assess degree of acidosis. Complete blood count, CBC. Arterial blood gases, ABG pH is often less than 7.3. Venous pH may be used for repeat pH measurements. Phosphorus. If the patient is at risk for hypophosphatemia, for example poor nutritional status, chronic alcoholism, then serum phosphorus should be determined. Hyperamylasemia may be seen even in the absence of pancreatitis. Repeat labs are critical. Potassium needs to be checked every 1 to 2 hours during initial treatment. Glucose and other electrolytes should be checked every 2 hours or so during initial aggressive volume, glucose, and electrolyte management. If the initial phosphorus was low, it should be monitored every 4 hours during therapy. Pitfalls. High serum glucose levels may lead to dilutional hyponatremia. Triglyceride levels may lead to factitious low glucose. High levels of ketone bodies may lead to factitious elevation of creatinine. Other tests. Electrocardiogram, ECG. Chest X-ray. Cultures. Imaging. Clinical management of DKA and recognition of complications. Fluid resuscitation. Intravenous solutions replace extravascular and intravascular fluids and electrolyte losses. They also dilute both the glucose level and the levels of circulating counterregulatory hormones. Administer 1 liter over the first 30 minutes. Administer 1 liter over the second hour. Administer 1 liter over the following 2 hours. Administer 1 liter every 4 hours, depending on the degree of dehydration and central venous pressure, CVP, readings. When the patient becomes euvolemic, the physician may switch to half the isotonic sodium chloride solution, particularly if hypernatremia exists. When blood sugar decreases to less than 180 mg per deciliter, isotonic sodium chloride solution is replaced with 5 to 10% dextrose with half isotonic sodium chloride solution. Insulin therapy. A low-dose insulin regimen has the advantage of not inducing severe hypoglycemia or hypokalemia, as may be observed with a high-dose insulin regimen. Subcutaneous absorption of insulin is reduced in DKA because of dehydration, therefore, using IV or IM routes is always preferable. The initial insulin dose is a continuous IV insulin infusion using an infusion pump, if available, at a rate of 0.1 units per kg per hour. Larger volumes may be easier in the absence of an intravenous infusion pump, for example, 60 U of insulin in 500 cubic centimeters of isotonic sodium chloride solution at a rate of 50 cubic centimeters per hour with a microdrip set. The optimal rate of glucose decline is 100 mg per deciliter per hour. A common mistake is to allow blood glucose to drop to hypoglycemic levels. This mistake usually results in a rebound ketosis derived by counterregulatory hormones. Rebound ketosis requires a longer duration of treatment. Potassium. If the potassium level is greater than 6 milliequivalent per liter, do not administer potassium supplement. If the potassium level is 4.5 to 6 milliequivalent per liter, administer 10 milliequivalent per hour of potassium chloride. If the potassium level is 3 to 4.5 milliequivalent per liter, administer 20 milliequivalent per hour of potassium chloride. Monitor serum potassium levels hourly, and the infusion must stop if the potassium level is greater than 5 milliequivalent per liter. Correction of acid-base balance. Sodium bicarbonate only is infused if decompensated acidosis starts to threaten the patient's life, especially when associated with either sepsis or lactic acidosis. If sodium bicarbonate is indicated, 100 to 150 milliliters of 1.4% concentration is infused initially. This may be repeated every half hour if necessary. Complications. The leading cause of DKA mortality in children is cerebral edema. Hypokalemia is a complication that is precipitated by failing to rapidly address the total body potassium deficit brought out by rehydration. Hypoglycemia may result from inadequate monitoring of glucose levels during insulin therapy. Acute pulmonary edema potentially is related to aggressive or excessive fluid therapy. Other complications. CVT. MI. Acute gastric dilatation. Erosive gastritis. Late hypoglycemia. Respiratory distress. Infection. Like, share, subscribe.